I was going to start with a few stories about our president since he was a lecturer in Manchester when I was training up there, but I've been told none of them are clean enough, so I'm just going to move on. So the first thing is, do I know what I'm talking about? Other people seem to think I do. They keep putting me on committees, so I've gone with the flow a little bit, and I hope I can pass some of that information on to you. But rather than stick to a normal lecture format, I thought I'd start with a quiz and make sure you're all awake after the gala dinner. So this is a question from, so basically this talk, I've gone to optometrists I work with and don't work with, and they've given me some of their burning questions. This one's from an optometrist down in London who runs a very large multiple, and he wants to know why refractive surgery only lasts 2 years. I think this is the answer. So, is it because it's a great business model? We can just repeat it every 2 years? To ensure that we're not going to send these patients back to you ever again? Because it's not a good procedure? All of the above? Or none of the above? I'm sure it's D, isn't it? It's all of the above. Why don't refractive surgeons have laser surgery? Because it only lasts 2 years. They can't find somebody any good at it. Again, because it's not a good procedure. Or all of the above, or none of the above. It has to be all of the above again. Why does the costs vary so much? I mean, you've all seen the adverts, $399 per eye. Some refractive surgeons are much greedier than others, obviously. Some chains want to take a market share of laser and glasses. Some clinics use technicians. What you see is not always achievable. So the companies advertising $399, most of them, the average price is $1,200 to $1,400, not $399. And of course, not all surgeons are doing high volume, so that does have a major impact on the costings. Not to mention the training levels. So one of the surgeons in Cindy's neck of the woods, not in the hospital, but in the high street, did 6 months ophthalmology training in total before he became a refractive surgeon. So he's done many thousands now, but you know, at the bottom line, he's not had his full training. So, okay, patients, I mean, what's we going to do with them? So, just as background, you know, how many procedures are performed? 18 million in America so far. I mean, it's difficult to get an exact number, but this is what is being quoted. 7% of their population. So we're not anywhere near that number, but you have to think that if 7% of your population are going to have this, then you need to be aware of this, and potentially you need to be involved. So I'll rush through this because I think a lot of this was covered in the last lecture. But basically, contact lenses aren't problem-free. Most of my patients who come for this are contact lens failures. We don't tend to go out looking for neophytes. You know, these are normally people who've gone through the contact lens route and appeared at the other end. So maybe the new materials and things will make a difference, and you'll retain them for longer. But my patients will be turning around to me saying, I have a problem for one reason or the other. And why do some of the optometrists not want to get involved? I'm sure the lack of knowledge is a large portion. I mean, in the training nowadays, I think in Aston, Shazad Naru does a 1-hour lecture on refractive surgery, which isn't going to give you a great deal of information to take on. It's just a touch. Obviously, something you're not familiar with, you may not be confident in, and you may not have the personal contact with the surgeon to make you comfortable. So, patients and optometrist carers need to have confidence in what they're doing. And those of you with sharp eyes will see. So, a lot of my patients have gone to a high street clinic, and just the way it's set up, and the fact they don't see somebody who they can put faith in, they leave. So this is somebody trusting their eyes to you, so they have to feel comfortable. And alternatively, there are optometrists who see this as an opportunity. Why? I mean, firstly, retain patients. I mean, it's less so now, but it used to be that patients did not want to go back to their own optometrist because their own optometrist was trying to dissuade them from having laser surgery. And so the bond has been broken, and that patient will go somewhere else for their future follow-ups. You can actually strengthen your links. If you're doing co-management, the patient actually comes to you and gets to know you a lot better. And you can attract new patients in. So either patients, if the word gets around that you're involved in refractive surgery, and so it'll attract new patients, but also it will bring in their relatives if they feel you're providing a good service overall. And of course, it's different. So some people like doing it just because it's different, and you will earn more out of it. So for people who are worried about their glasses sales, I mean, these patients are probably going to go and have refractive surgery anyway. So if you're pragmatic, you're going to lose that portion. But if you can retain them, and they'll be your patients in the future for either the small correction that they still have, or for readers, etc. So just talking about lasers now. There are some limits to the technology, so you might feel that the high street clinics are selling you that lasers can treat anything, but technology has its limits. Now, the bit I like here is the bicycle pannier on the side with the bucket as the baby holder. So there are ranges for laser procedures. But there are no real rules, because it depends on the laser, it depends on the surgeon, and primarily it depends on what the patient is expecting. So there are some patients, in fact I had 2 last week, both with prescription of -9 with a -5 SIL, same day, 2 patients. That's not treatable. And they were both 21, 23. So you're probably not going to go intraocular on them. So if you discuss this with the patient, they might be happy to be left at -2, -3. Because that's still dramatically different from where they started. So you do have to spend time talking to the patients. But in general terms, the limits for laser have come down, because this is what we know we can do relatively safely. So from about +4 to -9, the cylinder, you can theoretically treat anything. The practicality of it is, which is difficult, is aligning your axes so that you're actually treating exactly on axis, because you're measuring them sitting up and then you're lasering them lying down. So you have to have quite a lot of software to allow for the torsion of the eye as they lie down, when you start looking at these things, quite a few eyes taut 30 degrees when you lie down. So you might as well forget starting this procedure. So LASIK or PRK, I mean this is a surface procedure, so it's better for a thin cornea. I'm not going to go through too much in detail, but with LASIK you're cutting a cornea. So you're going to cut a third of the cornea, lift it up as a flap, laser it, and then put the flap down. So you've weakened it by the third just from the cut, and then you're going to remove some more. With LASIK, all you do is you remove the epithelium with alcohol, laser some off there, and then put the epithelium back on. So if you've got a thin cornea to start with, you can get away with doing LASIK. But there are some arguments for doing LASIK for every prescription rather than LASIK. High street clinics like LASIK because vision's instantaneous and the wow factor for the patient's high, and then they feel it's more likely that those patients will tell their friends all about it. But there's some patients you may not want this to do this to. Does it work? Now I'm not presenting my good results, I'm presenting my published results. This is a group, we're split into a spherical group, so less than a diopter of cylinder, and astigmatic group, more than a diopter. What I'd get you to look at is the range. There's no laser pointer assistant. No.
I don't know, can we provide a laser?
The range treated here was minus 9.5 out to plus 5.5. So this is including everything. This is not just the middle range where you're going to get good results. In the astigmatic group, the average cylinder was 2 diopters, but going out to 5.5. And if you look at the first couple of bars, so the purple is spherical and the blue is astigmatic. So you're getting 75, 78% within a quarter of a diopter of what you aim for. So, it's not a bad result. I mean, you've got, you're getting to 98% within a diopter, but generally those are the complex ones which are out. So, either they're the minus 9 with the degree of cylinder, or they're mixed astigmatism, and mixed astigmatism is slightly more difficult to do because you just don't know where it's going to, what the hyperopic shift is going to be from treating the cylinder. So is it safe? So a portion, this is at 3 months, a portion lose a line of vision. You might say quite a big portion, 5%, but we are normally talking 6.4 to 6.5 or 6.5 to 6.6. It's not sort of at the, because obviously these people are good vision to start with. But the interesting bit is how many patients are gaining vision, particularly with the high astigmats. And it's interesting that eyes which have been documented as amblyopic can get a reasonable amount of gain in vision. So which procedure would you choose to do if you're doing laser? It depends. There's no one procedure which fits all. So depends on the occupation, what they need, whether they've got dry eyes as pre-existing, even if it's borderline, if they're getting contact lens intolerance problems but no clinical dry eye without the contact lenses. Depends on the corneal thickness. So lots of depends. So you have to see the patient and discuss it. So I mean, I don't follow the where practically everybody gets LASIK. There's just some patients you wouldn't want to. One of my Irish colleagues had just treated 2 of the Irish team with LASIK just before this picture came out, and well, you can see that that if that had a LASIK flap on it, it would either be torn off. I mean, he's not going to have a good result, whatever happens. So is the procedure painful? LASIK, it shouldn't be. I'm talking after the procedure. No, the procedure itself shouldn't be painful at all. Remember that with the same proximethicane, amethicane, you do cataract surgery with, so you should be able to do LASIK without any trouble at all. So unless the epithelium is disrupted, there shouldn't be any pain. LASIK, you've lifted the epithelium, so there is a potential for a lot of pain. Remember, there are more nerve endings in the cornea than anywhere else in the body. So when I first did some, well, in fact, when we did some studies with Aaron Brahma in Manchester on this, people would put laser surgery, or not people, women would put laser surgery as more painful than childbirth. But that's if you don't manage it properly. So there are adequate ways of sorting out the pain relief, which you must give before the pain comes, so that the pain doesn't come at all. So, I mean, a couple of examples. I mean, I laser out in Jersey. Almost every time I'm over, we see people out in the evening after having had their laser. They just partly it's island culture and they just get on with things, but it's they don't seem to have a problem. Two of my staff who've had this done, one had hers at 9 o'clock because she wanted me to be fresh. She was still at work at 4, having had her laser, and the other one insisted on coming to the Christmas party in the evening after she'd had her LASIK. So the procedure, which in theory is very painful, doesn't have to be at all. Anaesthetic. Are you awake or asleep? Unfortunately, you're awake. You need the patient to fixate and centrate on the centre of the laser, because you're normally treating on the visual axis. So you don't really want to guess that for them. You can have some Valium, and if you're running a full theatre, then I mean, we have an anaesthetist available, so we will give intravenous sedation if we have to. But generally you prefer not to, because it's a dicey thing. Because if you give them too much, then they'll close their eyes. So one eye at a time? No, we generally do both. That's normal around the world. So what's the additional risk of doing 1 versus 2? If there is a laser problem, then you're obviously going to have that laser problem on both eyes. And there's a risk of, well, you have a risk of infection, but you will put both eyes at risk of the same infection if it's coming from something in your theatre or rather than the environment. In reality, it's not a laser problem, which is because the laser goes through numerous checks before you use it. So if there's going to be a problem, it's normally human error. There was one clinic in Dublin which had 2 patients of the same name on the same day, and they treated the myope as a hyperope, and so that certainly can happen. Infection, very rare in this. I mean, it's exceedingly rare. So and bilateral infection, unheard of. So yes, it's a risk, but not a huge risk. And it comes back to your relationship with the patient. If they know there's an open door, so if the eye's getting, if they're not feeling right, the eye's getting redder, the vision's going down, or the eye's becoming more painful, and they come in for a check. And you have to accept in these situations that 99% of the time you're going to say it's fine, but at least everyone's happy that there's no problem. So, but ultimately it's the patient's choice. So some patients will choose to have one eye done at a time, and they always regret it. Always regret it. Just going through it twice. And they always find the second eye worse than the first, just because they know what's coming. So, how long does the laser take? Any ideas? Yeah. I mean, it depends on the laser. The range is about 10 to 60 seconds, depending on, largely depending on the prescription you're treating. So, it's you can do a lot of patients, but because you've got to stick to check, double check, triple check everything, make sure make sure the preparation's okay. It's that which takes the time, getting the patient in, getting them prepped, rather than the laser itself. There's push to make these lasers even faster, but I don't know. At some point, you wonder whether if they get the 10 seconds down to 3 or 4, is somebody going to object to paying £3,000 for 3 seconds of treatment? Will you see straight away? Answer's yes. So you're not going to be covered up. You will be able to see through, whether it's LASIK or LASIK, whether it's you will be able to see enough to get around without any problem. What you won't be doing is driving, and you won't drive until you're legal to. I mean, we tend to request that the patients don't drive until they come back and see us, so that we can verify it for them. But I mean, ultimately they can check themselves if they have to. What about working? Yeah, generally no problem. So it depends on the population you attract. My population tends to be sort of middle class office based, so there's absolutely no problem. But I try and get them to see if they can do 4 or 5 days from home, if their job would allow. So for me, I tend to treat on Fridays, so they got the weekend to recover anyway, and then see them in the midweek, and hopefully they've taken it fairly lightly over the first few days. The reason not being that they won't be able to, the reason being that once in a while somebody will have a problem, and if they've made commitments that they then can't keep, that's actually more problematic. So you just tell them that you're erring on caution. So once you've done this treatment, will it change or get worse? It really shouldn't do. So in some patients you get some early regression. So you do a treatment, you have a good result initially, and then the healing process takes it back a bit, typically in high myopes and higher hyperopes. But especially if you're doing surface treatment, you can modify that with mitomycin, which is an anti-cancer drug. So whereas for cancer you would have it sort of injected into you, with this you just paint it on the cornea, and it stops the aggressive healing and works very well. Will I need any glasses afterwards? Now, it's wrong to promise somebody perfect vision. I mean, even if they come in at -1, if you promise them perfect vision, they may end up with something a bit odd. So I'm always very cautious of what I offer them. And if I have a patient who insists on absolutely perfect vision, it's better I don't treat them, because they will never be happy. So obviously they're going to need readers. So the vast majority of patients who come in don't understand that. I mean, a lot of patients come in pre-presbyopic saying, sort my both sides out now. So, generally with the laser we just treat the distance and then sort of readings up to the glasses. You can do monovision, and if you've done monovision, then obviously they'll probably want some night driving glasses. But all of this is about managing expectations. So I have a questionnaire which the patients fill out, and one of the first questions is, what are you expecting? And as soon as they write 2020 on there, the alarm bells ring, and then I decide whether I'm actually going to treat them or not. Whereas you know that if you go for somebody who's happy with an improvement, then you'll probably exceed their expectations. So we covered this a little bit. So the basic answer, if they're having laser, is no, it's not going to do anything for their presbyopia. But hyperopic treatments do give an increased depth of focus. So for a few years, they may, if you treat a +3 who's 45, they may get a few extra years out of it. But it's not a cure. You have the monovision option. I prefer to do that in patients who come asking for that, because that's what they're doing anyway. If not, I always send them away for a trial. So I send them back to their own optometrist for a trial. There are some presbyopic treatments where you change the asphericity of the cornea. Well, some people claim they're very happy with it. But they drop your distance acuity a bit. So most patients will end up 6'9", 6'12", and with a compromised near solution as well. And I'm just not very comfortable with it as a good outcome, because we spend the rest of the time trying to give good corneal shape, good corneal asphericity, and then just to treat the presbyopia, we go for a bad asphericity just so that they can read. So it may come, but I don't feel we're there yet. How many aftercares do these patients need? LASIK patients ought to be seen the next day. LASIK PRK patients a week later, and then a month, 3 months, and then routine optometric follow-up after that. So not a lot, but you have to build in to this that they may come back with problems. They may need hand holding. That's quite common. So, is it going to make your eyes more dry? Yeah. So this is a big problem. So most patients it's temporary, but in some patients it's permanent. And if any of you ever look on the American websites, one of the biggest complaints and litigation in America is dry eyes. So I tend to just tell the patient to expect to use lubrication for 3 to 6 months. If they don't need it, that's fine, but at least that's a seed implanted in their minds that they're going to need to do it. If they've got borderline dry eye, then I'll always go for a surface treatment. With LASIK, what happens, rather than LASIK, with LASIK you actually cut the cornea and you sever the corneal nerves. So the sensation for producing tears has gone down. So you will get more dry eye than on a surface treatment. And what's the best treatment if you do get post-laser dry eye? Actually, it's no different from what you'd normally do, but you just have to be more aggressive, and probably these patients are going to be more demanding because the dry eye is going to affect their vision. They're going to be unhappy with their quality of vision, and it becomes a bit of a vicious circle. So I think one of the questions asked was, what would I use? I don't. I like hyaluronic acid derivatives, but not all patients do. You know, so some patients like particular drops. So I tend to start them on hyaluronic acid, but say these are the options, and go away and try it. I'm not a great fan of Celluvis because of the largely the more effective one will blur your vision, and Optive is actually Celluvis in a bottle, more or less. So but it causes less of the blurring. But low threshold for punctal plugs. There may be some inflammation underlying some of this, so low threshold for steroids. And we don't have it easily available in this country, but Restasis, which is cyclosporin, is extensively used in America for this purpose. For us to get it, we have to get it in through an international pharmacy, and it's £150 a month, and it's quite problematic. So, can you wear contact lenses after laser surgery? If you have to. Yeah, simple answer. You know, fit may be a little bit more difficult. You might need to look at what you're using, but there's no specific reason why you can't. But whatever you do, this is surgery. Sometimes things go wrong, and then the question is, what do you do about it? In general, you just get on and sort it out. There's most of the things you should be able to sort out. But the key things here, like with any problem areas, is keep your relationship with the patient. I tend to try and see these patients myself rather than put up a barrier to seeing the patient. I mean, I had a patient just over Christmas who, well, a patient managed to give me viral conjunctivitis. I managed to pass it on to the patient who was having laser, who passed it on to her husband and her daughter. So she'd had laser, and she had infiltrates all over the cornea. She's sitting in the waiting room selling the procedure to the other patients because she's been managed well. She thinks we're wonderful. And you know, I'm sitting there worrying, vision's only 612, 615, because she's got an infiltrate right in the middle, and she's perfectly happy. If there's a problem, you need to be realistic. You need to explain the time scale. So if you're talking retreatments, it may be 3 months. Often the problems, particularly if, you know, go back to taking a history, lots of the problems are variable vision, and laser or lens surgery, it's often dry eyes. So it may be as simple as lubricating. So you can re-laser. If things are really bad, you know, IGP contact lenses if you've got an irregular cornea. And I've done, not many, I think I've done 3 corneal transplants for patients from high street clinics who haven't been managed properly. And so when a patient asks you, will they go blind? It's exceedingly unlikely, but obviously a corneal transplant's not a good outcome if you've had laser surgery. So this is another one question, but why does it mess up your night vision? So, you know, there are some people think it messes up your night vision all the time. But it depends a little bit on pupil size, because if the pupil gets bigger or to the same size as your ablation diameter, then you'll get some edge effects. Particularly on a high treatment, you will reduce the contrast sensitivity for up to 6 months. And I had a surgeon recently I did, and I had to point blank refuse to do both eyes at the same time because they were -9. Because you were just worried about them working afterwards. So we actually left it 6 months between eyes, and came back and confirmed it was the right decision because it was down for a while. So you can decenter your ablation, which will cause a bit night vision problems. Obviously, if you've had LASIK, then there can be flap or surface irregularities. Okay. Now just going to move on to refractive lens exchange. I mean, this is probably the biggest sort of change recently. I mean, in my practice, this is now 80% of what I do. So patients will come in for laser, but often they'll walk out with this. Again, I don't have a typical patient group, so that explains part of that. But you'll see from the results why people will choose this. So again, this is my data, which has been published. So 41% of these are high myopes, and the range -6 to -18 in this group. I've had 2 this year who are -27. And if you think, for both the -27s have ended up at 6.9 unaided, and the change of life for them, you know, they're coming. In fact, both of these 2 came in crying because you know, one of them was I didn't quite understand how he'd been grandfathered into HGV driving with his prescription, but he had. But I think he was about to be found out, so we had to do something. But he's retained his career just by doing that. Nearly 60% are moderate to high hyperopes, so 3.5 up to 10. Once you go beyond 10, or it's actually more to do with how small the eye is, the risks start increasing dramatically. So they're not young patients, but they're also not that old either. So results, I mean, the post-op mean close enough to 0. Obviously that's the mean, but the range was +1.25 to -1.25. So from the extremes that I was talking about, that's I felt that was acceptable. 94% within a diopter, 97% were 6.12 or better, 67 were 6.6 or better. So, and just keep coming back to, you know, these will be the -15s that you're doing. So gain in their best potential vision just from magnification in 40%. So we've done a few to, you know, whether they're slightly amblyopic, but they were just getting to, sort of not getting to, they've just been on the borderline for driving anyway, and then you get some mild lens changes, which you wouldn't really call cataract, but they're very mild changes, and they're driving threatened. You do this, and the magnification gives you the edge. So only 1 person lost the line of vision, and that was from 6.5 to 6.6. And this is what I was talking about before. 2 supposedly amblyopic eyes went from 6.12 to 6.5. This is a known phenomenon in even if you've got a densely amblyopic eye and you lose the other eye, the amblyopic eye at whatever age you are can regain some vision. So this is something to do with that. So all of this comes down to very accurate calculations, biometry. If you use the wrong lens, you'll get the wrong result. So in my group, 64% were so this is a separate study, but the 64% were within 1/4 of a diopter. The figure in brackets is a comparison to a large published study in another journal. So 83% were within 1/2 a diopter, and 99% within a diopter. So you know, if you're doing refractive surgery, this is, although it shouldn't be different from NHS cataract surgery, just the practicalities of it, you've got more control about what you're doing. And your audit systems, or certainly my audit system's better, so we feel we're doing reasonably well, and we certainly seem to be doing better than other people on this. Then this is Phil Buckhurst, who's in Plymouth now. This was his PhD. This is looking at, these are defocus curves, so these are looking at multifocal intraocular lenses. And what you're seeing here is, this is in logmar, so 0 logmar is 6.6. So if you just look at the red one, which is both eyes, at a defocus of 0, so for distance, they're all doing very well. And at a defocus of 2.5, so at a distance of about 40 centimeters, they're getting reasonable reading, but not what they tend to get is about N6 to N8. But there's a dip in their intermediate. So what this is trying to show is that I mean, you can get the same sort of graphs for multifocal contact lenses, but none of these lenses are perfect. So they will give you generally good distance. They give you good reading, but not perfect reading. And intermediate is, with this lens, is better than with a lot of lenses, but it's, again, intermediate's not perfect. So if you're putting these sorts of lenses into patients, they need to be counselled that they may need to change their working distance for their computer, and they're likely to need reading glasses for very small work as well. But you can put these lenses into, these come as multifocal torics, so you can you can treat a -15 with a -6 cylinder astigmatism and get them pretty functional without. But it goes back to, if you counsel them properly, they're not going to mind that they're not perfect. So poor results. This is a Brian Tompkins picture on one of my patients. So dry eye, almost invariable after lens surgery. It's not talked about very much, but it's always there, and these patients need to lubricate as well. Multifocal lenses, you do get photopic phenomenon, so you need to warn patients about sort of glare halos. Depends on the choice of lens. The ones I use at the moment are segmental bifocal, so they're multifocal lenses, but they look as if they have a bifocal segment on the lens. So what they've done is they've made the multifocality only in 100 degrees of the lens, so the light transmission's a lot better. Some of you may have tried, there is a contact lens of that sort which has been available from Belgium for 20 odd years, but it never took off, and I suspect it's just because it moves, you don't quite get the segments in the right place. But inside an eye, they work very well. You can get ghosting. If you get a poor refractive result, you can laser these patients on top. So generally, I prefer to do LASIK rather than LASIK, but that's personal choice. So co-management, I'll have to speed up a little bit. Is this what everyone worries about? There appear to be almost two camps, that the for refractive surgery co-management and the against, and there are not that many people who just dabble in it a little bit. So, few questions. What's the position on indemnity? I think, correct me if I'm wrong, but as long as you're working within an area of expertise or training, you're fine. So for laser, you may need to, you may need a little bit more training, but essentially it's an anterior segment examination, which all of you are able to do. Ideally, you work within prescribed parameters, and you have a procedure for complication management. This is just to cover you from a sort of governance point of view. And so when do you refer back? What's urgent and what isn't? Well, hopefully you wouldn't ever see the situation where the lens isn't sitting in the right place. But you know, obviously that needs referral, but that what you need to do first is agree these sort of things with the surgeon. It's best to be able to contact somebody because what you feel is urgent, the surgeon may not feel is urgent, and rather than send a patient unnecessarily, it's easier just to have a conversation before you send. With LASIK, the only real urgent thing is infection, so it'll be this look the same as a contact lens related infection. With LASIK, you need to be a bit more aware about the flap and how it's sitting, and that can be urgent. With refractive lens exchange, it depends on the if there's infection or there's a wound or lens issue. So when you're deciding whether to refer back, I mean, if you've got topography, if you've got OCT, you can assess the tear function, that's great. I'm just remembering whether this one's one of yours, Nick. I think Nick's in the back somewhere. Okay. So you know, so with Nick Rumley and I have had a couple where they've got some mild macular edema following their lens surgery. So the treatment for that is steroid and a non-steroidal. Nick's an independent prescriber, so we just sort of discuss what to do. One of the patients, the pressure shot up, so we discussed what to do on that front as well. Depends. You know, you do what you feel you're trained up to. I think we've covered that. So why do you pick a specialist surgeon? Well, I think so that you know what you're getting, firstly. If you refer to a high street clinic, the difficulty is that the surgeon's not named until the day, often, for the patient. So even if they wanted to check up on the person, they may not be able to. Patients are more comfortable if they see the same person. The co-management is easier because you know, email, phone, there is an answer. If there's a problem, because both parties know each other, that can be managed well as well. Now, referral fees versus paid co-management. So I'm just going to very quickly touch on this. So some people want referral fees for, fees for a referral without doing any work. And some people will say that's not acceptable. And the GOC has a guidance on this, and that any payment is in keeping with the amount of work performed. So if you expect, and there are a lot of people out there who do, if you expect £200 for writing a letter and not doing anything else, is that what you'd expect for writing a letter to the local consultant surgeon for a cataract, for a private cataract? If it isn't, then you need to look at it. But it is a grey area. It's not set down and prescribed. This is exactly what you have to do. So this is where your difficulty comes in. But I think, I mean, certainly I try and be squeaky clean about this. And you, as an optometrist, are supposed to declare to the patient what you're getting out of this anyway. So wherever the money comes, you should be telling the patient. And so a lot of this comes back down to what your rates are and what you feel is acceptable. And these are the very last few. So if you have a cataract in a LASIK patient, that's a problem. Because the measurements, the biometry that we do is inaccurate. So there are algorithms that you can use for this, but ideally to use these algorithms you need the pre-op Ks, post-op Ks, and pre- and post-op refractions immediately after surgery. So, because what you don't want is any index myopia coming into the calculation. So ideally you want the patients to keep a lot of data. And you need to warn the patient that this is a risk. And You need to do an early refraction because if you're a long way out, you may need to swap the lens. And you can re-laser these patients. I think this is the last one now. Annual eye checks. What do you need to look out for? So we published on this when I was in Manchester many years ago that laser surgery apparently drops your intraocular pressure. So typically if you have a -7, -8 treatment, your intraocular pressure will be down by 5. So all your laser patients are effectively normal tension glaucoma patients. You know, they may behave like with a normal pressure, but you have to keep going on the fields and the discs. You can use some compensation factors. So you know, if you know what they've had treated, then you can adjust a little bit, and there's some nomograms for that. But first thing is be aware of it. Obviously, it's still a myopic eye, so look out for the myopic problems. These patients are less tolerant to early cataract, and this happens fairly frequently, unfortunately, that increasing myopia is put down to a regression of the result, even if it's 15 years down the line, and nobody looks to see that they're developing cataract. So, is this one of your comments again, Nick? It's, so when we started this talk, I just asked for some questions and comments, and I'm sure this was one of Nick's, that refractive surgery is not a threat to business, it can actually enhance your business. But ultimately, this is all about teamwork, and thank you very much.
Okay, so thank you very much, Sunil. So we do have time for some questions now. So we do have some roving microphones. So if you put your hand up, just got one here, first of all.
Could you tell me which past corneal conditions or conditions that are in remission would mitigate against you performing any of this refractive surgery?
What sorts of things you talk about? Dystrophies or?
People who'd possibly had previous, maybe herpes infections or other sort of corneal infections, endothelial problems, things of that sort.
It's on an individual basis. So if you go to a high street clinic, if they've got anything wrong in on the cornea, the likelihood is they won't be treated because they'll fall outside of their parameters. If you're going to a corneal surgeon, they'll look at it on a case-by-case basis. So a single episode of hepatic disease, still quite risky, but you can cover it with acyclovir tablets to try and prevent remission. So nothing's impossible, but it just depends on what it is. Bacterial infection is not normally a problem. Viral infection, because it's still sitting there, you're quite reluctant normally.
Thank you. Any other questions just here?
What's the youngest age you'd do the surgery on?
It's if you're looking at sort of 18, 21-year-olds, I mean, what you're really looking for is stability of prescription more than specific age. So ultralays used to set their limit at 18, which I felt was a bit young. Most people go for 21, but you know, if you've got 2 years of stability before that and they've got a small prescription and they understand the issues, then I don't have a particular issue. It's probably a good treatment for young children who've got particularly myopic anisometropia. So there are studies going on where it's done for that, and so there's no definite cut-off. It just depends on what you're trying to achieve.
Thank you. Sorry, Gordon, then Garant, please.
Hi. You've alluded to possible malpractice within the laser surgery field. Do you feel that the industry is adequately regulated? Because I think most of us have come across cases where it seems that people are giving poor advice to patients. I've got a patient who's treated in the mid-2000s with a radial keratotomy, very successful result for about a year, and has gone from being a -3 myope to now having 450 cils, and a very interesting topography reading. So it's really whether some of these practitioners may bring your profession into disrepute or damage your business model.
But I don't worry too much about my business model. It's a difficult one. There was a all-parliamentary review back in '97 when it was suggested that this was regulated more, and actually got to a stage within the College of Ophthalmologists where there was some thought about bringing refractive surgery into the standard training scheme so that everybody had some degree of exposure, and then some people could branch off and just do that. I don't know the ins and outs, but certainly one of the issues at that point was one of the high street companies put up a legal challenge saying it was restricted practice. So it's a difficult one. I mean, it's plastic surgery is the same. You know, they're all fields which could probably do with more regulation, but as the regulation comes from people within establishment, it's often seen badly by the people who are not within the establishment.
In the long term, in LASIK, what holds the flap on? In the short term, what holds the flap on? And in the long term, does scar tissue form between the flap and the underlying stroma?
In the short term, it's just sort of hydrostatic suction. You know, it just sticks back on, but it's still mobile. There is some reaction over time, but you can always lift it. I mean, I think the furthest one I've done has been about 15 years out, came up straight away. So, I mean, there are a lot of corneal surgeons who are shifting on to surface treatment, because if you've got something which is never going to heal, then it's always going to be an issue. I mean, I'm in the middle of doing, the forces are looking to introduce refractive surgery for their high value personnel. So I'm in the middle of doing a pilot study on the SAS, and we decided at the outset that they can't have LASIK. You know, I mean, you saw that picture of the rugby player. Somebody in the SAS gets poked in the eye in Afghanistan, and the flap comes off. What they're going to do? So the forces are likely to go purely for surface treatment on a safety basis.
Okay, we have a question at the back there. Professor Jewell. And then we'll take the last question just in front. Yeah.
Thank you very much, and thank you, Sunil, for an excellent talk. I just wanted to comment on that question about regulation. Bruce Keogh, who's the medical director of NHS England, has undertaken a review of cosmetic procedures, and to the College of Ophthalmologists, we wrote to him to include refractive surgery in it, which he did. So, and he has personally written back to me saying that all the recommendations coming out of that review of cosmetic procedures will include by name refractive surgery as well. So I think we will see some government action after all.
Thank you. So just our last question here from a lady who's been waiting very patiently.
For an adult with binocular vision problems, so a +4 hypermetrope with either a fully acom or partially acom, is that something that would be treated, or it's too unpredictable that they're sort of fully acom will stay fully acom if you get rid of their prescriptions?
Again, it depends on sort of the teamwork. So normally I send to one of our orthoptists who I work quite closely with, and if she tells me that the risk of post-operative diplopia is low, then we go for it. But the patient needs to be aware that, the other thing you need to do is surgery's got to be very quick between eyes. So I tend to do it a couple of days apart, because either that or they've got to keep a contact lens in the other eye, because if one eye drifts off completely in between, then you'll be in trouble. But I've got the backup of a squint surgeon behind me, so these are the patients. You know, it's horrible being +4, and once you've explained to them what the risk is, if they still want to go ahead and they understand there may be other issues, then that's fine.
Okay, well, let's thank Sunil again. That's been a really